We're talking about medical insurance on Monday special tonight, and there's been such a low uptake of medical insurance in Kenya. We're going to show you those figures right now. This is according to the Kenya Demographic Health Survey of 2013. Those insured in Kenya or under medical insurance, 17.1%. That's just about 7.6 million Kenyans. 83% are not insured, and that counts for about 35 million Kenyans. Now, counties with the highest coverage of those insured: Kiambu leads 34, Nyeri, then Nairobi. Interesting, everybody may have thought Nairobi should be leading. We have 31, Kericho, and Kirinyaga 29. Counties with the lowest insurance coverage: Trans Nzoia 5.4, Tana River 5.1, Kwale 4.6, Turkana 3, and Marsabit 1.8. Right, keep talking to us on 22422 on Twitter using the hashtag Monday Special KE. Our guest tonight, I'll start on my left, Simeon Kirgotty, CEO, NHIF. Thank you for making time for Monday Special. And Olunga, Secretary General, KMPDU.
Thank you.
Thank you so much for making time tonight for Monday Special. I'll start with you. Why do you think there's been such a low uptake in this country?
Thank you, Sain, for this is a very important discussion in terms of a key pillar in health system strengthening. And actually, the part of the SDGs now is universal access, and part of universal access is universal access to healthcare. And we can't have universal access to healthcare if we do not have health insurance. The reason why we have uptake that is not adequate is because we are not employing the mechanisms to actually really encourage the people. And I also want to go back to the policies that we've put in place to drive universal health coverage. And I think this falls with the policies that we've put for health and to encourage not just insurance but also healthy living, and also what NHIF has been doing. I want to say that actually NHIF has tried, and the truth is that there's been some improvement. Right now, I think up to about 6 million Kenyans are on NHIF, which is quite a significant increase from the last 2 or 3 years. And but the problem with these figures, including the 17.1% that you talked about, is how effective is this insurance? Because most of the insurances in this country are plastic. What I mean is that they're not effective. You have that NHIF card, but you can't access the services. So it's as good as sometimes not having it. And it also includes even the private sector. And you also talked about Nairobi being low. It's because it has quite a lot of working class poor. Working class poor means that there are people who do not have predictable and stable income even though they work. So they actually have no way sometimes of affording that amount. Yes.
We quoted that from Kenya Demographic Health Survey of 2013. Obviously from last year there was a big rollout from NHIF. First, do you think the numbers have changed, and have they changed significantly?
Yes, Hussein. The numbers have changed, and thanks a lot for Kenyans for embracing especially the outpatient scheme. You know, when we enhanced the rates, there was a lot of pessimism that we are heading nowhere, that we are likely going to just get this money and utilize it for projects as it is. But I'm very happy by the number of Kenyans standing up. For the last 2 weeks, we've been telling people to choose facilities, and the turnout of people coming to choose facilities of their choice has been numerous. Now, about the uptake of health insurance in Kenya, health insurance is a foreign concept, and many Kenyans believe religiously, and they think that God will take care of, their health. One of the biggest challenges we have now is what we call in health insurance advanced elections, where people become sick. That is when they know NHIF is important. So we put, you know, controls such that you don't just walk in, become a member, and the next day you can utilize your card.
Right.
You have to stay for a period so that we can be able to track your record.
It just doesn't happen immediately.
It doesn't happen immediately.
How long does that take?
3 months.
3 months.
Yeah.
Okay. It's important to point out here that we tried to get private insurance providers. They were supposed to come for this show, but for some reason our guests could not make it here tonight. You were saying, and especially on NHIF, that it's just plastic at the end of the day. It doesn't work. Why do you say that?
You know, it's because of the way the healthcare is currently in the country, and we have to agree here that as much as NHIF, I mentioned, have done well to probably bring in Kenyans, but what is happening is that those Kenyans are not accessing quality healthcare. And you know, when it comes to health insurance, there are two things that are key why people get health insurance. Number one is not just the issue of affordability, although that's also an issue, but also access. And access is in two forms. You can access the facility, but then you're not accessing the care, because either the facility does not have the equipment, or does not have the doctors, or does not have the nurses that can provide that care. And the other thing about the NHIF, which is prohibitive, is the exclusions. And I think it's important to mention the exclusions here, because you have the NHIF card, whether it's public or private hospitals, but you need this MRI, you need this CT scan, which are tests that will help doctors make a diagnosis, but it is excluded from the service. It's not covered.
We'll come to that. We'll come to that. I want him to respond to how effective it is. And maybe let me pick one or two SMSs here. P. Muredi in Nairobi says, ask Kirgotty why the NHIF cannot cover me at any hospital I visit. The absurdity of this scheme is that I must choose a hospital I wish to be visiting, contrary to other insurances which cover a person anywhere they visit.
We have two schemes here. We have the inpatient scheme and we have the outpatient scheme. With the inpatient scheme, you can be admitted in any hospitals. These are hospitals we pay through rebates, with an agreed rebate.
Any hospital, public, private, it doesn't matter.
It doesn't matter.
And it covers what exactly?
You see, we have three categories of hospitals. We have categorized them into A, B, and C. With government facilities, it is regarded as category A. You walk in, you walk out. We have faith-based hospitals, that is mission hospitals, and semi-private hospitals who have signed up with us. So we have different categories of hospitals. So
government and mission, you walk in, you walk out.
Yes.
That's what you're saying.
Yes.
Both inpatient and outpatient.
For the outpatient, that's where I'm coming. With outpatient, you have to choose a facility, because we pay these hospitals using what is called a capitation model. A capitation model is where we pay money in advance to this facility to await for any member of NHIF. We will go there and we'll check that your name is there, and then they will pay you. They will attend to you. And that is why we are asking Kenyans. You know, the outpatient scheme is quite a new thing, and that is why Kenyans are finding it. They are used to the so-called bed. You just go to bed, you are admitted, and then you pay. We have moved from there. Yes.
Just to make it clear to Kenyans, the way you're talking. Outpatient in mission and government hospitals, how much?
You see, for outpatient, you have to choose a facility.
Yourself. So if I choose a facility, and that is the question being asked here, and I can pick, because there are a lot of questions coming in, I'll try and ask them as many as I can. Somebody here says, I pay for NHIF, but I'm not happy with the selection of hospitals. I live in Nairobi, while my children and my wife are up country. That means if I choose a hospital in Nairobi, my family has to travel to Nairobi for medical attendance.
No. If you are civil servants working in Nairobi, you choose a facility in Nairobi, and you indicate to us that your children are also in Siaya or wherever, we will take those choices. We will not tell you, transfer your children here. That should be very clear.
Okay, I think CEO has clarified that, although Kenyans must understand, and I think he will agree that we have discussed these issues, and even with the civil servant scheme, we have discussed this issue, and I think this is the #1 problem. And it also creates a lot of inequality because hospitals basically do not have the similar services, do not have similar quality of service. So someone who is capitated, or has chosen Kenyatta National Hospital as their provider, and another one who, for example, is in Turkana, they are not going to get the same quality of service.
That has no problem, because we have a referral system.
Yes, but that's not the only problem. Also, as the gentleman has mentioned, I think that provision hasn't been there before, unless you want to assure us that it is there right now. That sometimes your family or the dependents stay far away. Occasionally, also work takes people from different places. Okay, and people are transferred even within that same year. And for Kenyans, it's very important that they access quality health care wherever they are, whether it is inpatient or outpatient. And I'm sure this is not the first time the controversies around capitation are coming in. So capitation is limiting people access to health care because hospitals are not equal in terms of the care that they provide, and also because sickness does not choose places.
Yes, we have a clear portability system and referral systems. If for any purpose the hospital which you've chosen and NHIF has sent money there is not able to pay to you, to attend to you, you are referred to higher hospitals, and then there is a way in which NHIF will be able to deduct whatever this hospital was not able to do.
But the question here is, if I could get that question, it doesn't make sense, somebody says, it doesn't make sense to register to a certain facility. Does it mean if I get sick while on transit, then I have to travel back?
No.
So even about, okay, let's talk about let's talk about outpatient cover here.
Exactly.
If you are covered by NHIF and you have chosen you chose a hospital in Nairobi, and you travel to Kisumu and you still want to access outpatient cover, what happens?
You see, NHIF is highly automated. By the moment you have an NHIF card, if you got sick in any hospital,
anywhere in the country,
and it's an emergency, it is just logged in, and it will show us that Hussein has been admitted here or has been attended here. What we will do is we will be able to get back to your facility of choice. You know, this payment, just for clarity, you're saying if it's an emergency. If it's not an emergency, somebody is sick, I just want to access. In normal circumstances, you should go to your facility of choice. But how is so that we can be able also to build those facilities?
But is that really convenient for people who are paying for these services at the end of every month? How convenient is it for them? I mean, if you're traveling from one part of the country to another part of the country, then you tell me I have to go back to the hospital.
No. Let me assure you, you will not be told to go back. And there is no hospital. You will go there. You will go and they will tell you, we cannot attend you because you had not chosen us.
We're getting SMSs from people who say they've gone to these hospitals and they've been told, you're not registered here, you have to go back to where you're registered.
No, then I'm going to make it very clear to them, because first and foremost, a Kenyan must be attended when he's sick, whether he has paid NHIF or not. That is one thing. So the issue of somebody
but we're talking about those who are covered by NHIF. To be clear. So was there a need then for people to register specific hospitals?
Yes, it is, because of the capitation model. You know, these hospitals must be paid in advance so that they can be able to equip themselves, they can be able to get medication, so that when our members go there, they do not have any problems about it.
Is there any other way around this?
We're saying there are a lot of issues with capitation, and I can understand the challenges that probably NHIF...
And it is accepted worldwide, by the way.
Of course, NHIF is not the first insurer to adopt capitation rather than fee for service. But capitation here has a lot of issues. Number one is leaving the patient to choose whether this is emergency or not. And I think I can be very clear that most of the facilities, especially NHIF accredited facilities that offer outpatient services, most of them have specific clinics where you are seen.
Yes.
And some of those clinics in many hospitals,
Yes.
The truth is that they do not accept walk-ins. If you are not registered in their panel, they won't see you.
Yeah.
Of course, there's no hospital in this country that will tell someone to walk away, but you will be seen elsewhere, and you may have to incur costs out of pocket, and yet you have an NHIF card. And the question here then is, if people are able to access services, irrespective of whether they are registered there, then does it really make sense to have them locked to a particular facility? And the other problem with capitation, which we've also discussed, is that sometimes the providers, the amount is too low. It doesn't cater for the cost of healthcare. Yeah. Like I think for now I'm not so sure whether it's 17. It's 17.
It is not low. It depends on the numbers. You see, capitation depends on the numbers. The more people that choose the facility, the more numbers you get, and the more capitated amount that will come to you. So you see, it also creates competition. It also makes hospitals better their services, because people will not choose ramshackles.
That's the other side of the coin.
Yes.
But on the other side, more volume could actually mean more losses for hospitals, because if you're giving 1,700 per family per year, I think that is it.
1,200.
Yeah, sometimes 1,020. Actually, previously even 300 shillings per family per year, and one person can consume up to 21,000 just in an outpatient visit.
But it's not one person. You know,
yes,
you don't
I do understand. I look at the risk. I look at the risk, and I know actually a facility that has 77 people registered, and they were paid 300 per person. That's 21,000. Then one person comes in and they have consumed all the services for the others. But also, even if you look at a facility that has millions, actually more people could actually just mean more losses. And I'm talking from the provider's perspective, and because doctors see these patients. So there are a lot of challenges with capitation that I think needs to be looked into very carefully, and especially with people choosing facility, because I think it limits access to healthcare. And you know, when we can't be talking about universal health coverage, and on the other side limiting access.
Do you think it's the best model, or are you thinking of reworking it?
Yeah, before we went into capitation, we went all over the world checking on the best model. And my friend Dr. Olunga knows very well that the other alternative could have been fee for service. You know what fee for service is? You go to any hospital, they treat you, and then they bill NHIF. Yeah? So you can imagine the volume of paperwork that will be in any of NHIF offices.
But you cannot really...
So...
that is not a good model, according to you?
You know, there are pros and cons for both.
Yeah.
In a model like NHIF, personally what I would propose is if we're looking at uptake and we are looking at proper administration of the fund, I think fee for service would be good, because we are looking at health access. We are looking at the people first, not the paperwork, not all of this aspects of provision.
What I agree with Daktari is the issue of quality.
Yes.
And this is where we want to partner with the doctors.
Yes.
That's why I really would have wished we had
a private,
insurance provider here.
Right.
So that it should not just be money from NHIF.
Yes.
It should be service to the people of NHIF.
Right.
And that's why my quality assurance officers are running up and down.
How low can one pay to access medical insurance and quality? Those are some of the questions we're going to come to and going to ask here. Let's take a look at what you've been saying first on Twitter. George the poet: I used to have NHIF when the charges were 160 per month. When they quadrupled that to 500, I could not keep up. Biko Bimbo, NHIF outpatient scheme is good, but the hospitals and the county governments are giving poor services, defeating the noble scheme.
That's true.
That's true.
At Toronto KD, the outpatient has not been readily accepted by many private hospitals. Only 2 private hospitals could accept in Nakuru.
No,
And Nancy Okuta, NHIF only works in specific selected hospitals. Lack of national IDs has hindered issuing of medical cover. And I'll go to the NHIF CEO very briefly. A lot of questions coming in. We hope we can try to ask all of them. That's almost impossible, but we'll try. What is the lowest income you need? It's 500 shillings,
yes.
I think, at the end of the month.
Yes.
And 1,700?
Yes. So,
are all accessing the same benefits, and what is it they're accessing? Outpatient and inpatient, very briefly.
You see, NHIF is a social cover, where whether you pay 500 or you pay 1,700, we put them in a pool. Yeah?
Yeah.
And we try to give benefits as much as, equal benefits as much as possible.
Yeah.
However, of course, those who are paying 1,700 are able to access certain high-end hospitals. Say, category C, you see, these high-end hospitals, like the civil servants, for instance. The civil servants still pay the statutory 1,700,
yeah.
And then the government has also added something to the scheme.
Yeah.
Yeah?
Yeah.
So they will be able to get some superior kind of scheme. Now, for the 500, the 600, the 700, you will be able to, depending on the category of hospitals you've chosen. If it is government hospitals, you don't pay anything when you go there.
For outpatient?
For outpatient, you don't pay anything.
You don't pay for drugs?
You don't pay for drugs, you don't pay for consultation.
Because you're getting a lot of SMSs, people saying they are still forced to buy.
No. Report those officers to me.
But
yeah.
Those reports are true, because and I've seen this, and even let's look at even the people with cancer, which is now the bigger discussion in the country.
Yes.
You were told you have NHIF, but then you go to Kenyatta National Hospital, they don't have that drug, and you see you still have to get it. So
those one we got, and that is why you've heard me announcing that from the month of February we are going to have a special fund for chronic diseases.
Yes. Okay. Yeah, but also for even just common ailments, you're given a prescription of a 5-day antibiotic, which that particular hospital does not stock. You're not going to wait.
Then that is wrong. That is wrong.
But you see, they don't access it because of course, those are not issues with NHIF. It's issues with healthcare. It's issues also with, as you mentioned, those county hospitals. Some of them are just there. The doctor has left. Some resigned. They're not there. The drugs are not there. So you have the NHIF card, but you can't get the service. So that's something.
There is what we offer,
I know,
and what they refuse to offer.
Exactly.
And those are the things that should come to us.
Because but how do they get to you? This is somebody who is sick. He's going to a hospital someplace in Turkana. How do they get to you?
No,
they are frustrated. They know they pay at the end of the month.
Yes.
They cannot be able to access some basic. What do they do?
We have inspectors. We have quality assurance officers all over the country.
All these hospitals?
In every county we have an NHIF office. We are in 98 stations in this country.
Yeah, one thing I want to agree with is that is not specifically for him to answer, because there are services that NHIF does, and then of course there's the bigger healthcare system.
Yes.
But I think I want to look at it from what then can the money that comes to NHIF do to improve public healthcare, because most of your facilities are actually public health facilities.
Yes.
But coming back to the questions about costs, I think in my own opinion, I know that NHIF has struggled to do a lot of improvements, but it has also created a pool of the haves and the have-nots. And I want to say this, like you find that there's categories of people, all of them paying 1,700, but one can access certain facilities and not the other people. And also, you know, I think that
which
is
could be unfair to others.
Which is unfair to others. And I know that those are things we can work on, because right now you have done well in terms of increasing the numbers.
Okay.
But I think in terms of oiling the cogwheel to make sure that these numbers are actually translating, I think there we can.
What we need to say is collaboration with the Doctors Union. They can be very good ambassadors of NHIF.
That's true.
In wherever they are, especially the way they have assisted us in increasing the numbers. When people go to see them, they ask them for NHIF card. They should also assist us in checking on the quality which my members get. I really get very annoyed when people are paid and whatever services they get there are poor.
Sometimes, this question to you, sometimes people say the problem is doctors. When you go and you're told we cannot offer you any services here because of your card or whatever you're insured with, like NHIF cards. We've seen some complain about that.
I have not heard about that.
You must have heard about it.
No, you must.
It has been there.
But
even the medication they give, sometimes people are told, do I give you, do you call it original
or generic?
Or generic.
You know,
and we don't pay when NHIF pays you.
I mentioned
we
that
are not paying you so that you can give out generic.
You know, I think NHIF has accredited facilities and not specifically doctors. You can't say that NHIF has a panel of doctors.
Who runs?
So of course it's the hospitals are run by quite a number of people in management, health administrators, and doctors are part of that. I must confess, doctors are part of that. But of course there are challenges with the healthcare system. There are challenges with procurement of drugs in many hospitals, which of course goes to questions of how we manage our healthcare system, issues of leadership and governance, and therefore there are sometimes shortages. But I think I want to agree with you that that there are some things that we can do together, partner together, and I think we have discussed this before, including actually making doctors be ambassadors, but even that also trying to make sure that doctors actually can access these services in whatever hospital.
I want to go to specific questions now from the public, but I want to get something clear from you, Bwana CEO.
Yes.
First, you say, okay, let's deal with the lowest category here that pay 500 shillings.
Yes.
They can go to these hospitals.
Yes.
Outpatient, it's walk in, walk out.
Yes.
Inpatient?
Inpatient, we have specific rebates. Yeah, we pay an hospital, say 2,400 for, you know,
for the bed.
Green amount. We don't call it a bed because it's not some hospital beds you don't pay 2,400. This is for consultations, you know, minor surgeries.
That's for inpatient.
That's for inpatient. So
if they go there, that is what they should expect.
Yes.
Now, the other issue we're talking about, choosing hospitals.
Yes.
You're saying if you are sick, you fall sick, my hospital is in Nairobi, and I fall sick at some place in Marsabit, they should go ahead and access?
Yes, you should go ahead and access.
They should not be stopped, because many people are saying they are told they cannot access.
No, report services. Those ones who are saying like that. You are supposed to report there.
So they should go ahead and access.
That's it.
They should go ahead and access the services. Okay.
But you should do as much as possible. Build the hospital of choice. Right?
Okay.
Yeah.
All right. I'm going to go to specific questions here. Sylvia from Eldoret says, I'm a 50-year-old farmer and not insured. They say I'm overweight and therefore cannot insure me. Medical cover is intended to cover the individual access treatment. They discriminate on plus-size people because they are prone to lifestyle diseases.
That lady is not talking about NHIF.
Yeah, she's talking about private.
Because NHIF has no exclusion, and that is what I wanted to clarify with my friend here. I actually wrote it down. NHIF has no exclusion, has no age, there is no disease that we cannot cover.
Right.
So
there's no disease that you cannot cover. Dennis in Kisumu says, why do we still pay for chronic diseases and treatment like dialysis, yet we pay for NHIF? This is somebody talking about NHIF.
Yes, that's what I was saying. We have created a specific fund for chronic diseases.
So as it is right now, you're saying
as it is now. Yeah, as it is now, of course.
They're not covered.
No, they are covered, of course. But you see, the covering is on rebate if you are being admitted. But for dialysis, for instance, we have specific hospitals where NHIF members go.
That's true.
Yeah, and we pay.
That's true. But the exclusions I was talking about are exclusions to service. And I think...
But not exclusion because of age.
Yeah, not exclusion to admission.
Because of a disease.
Yes.
No.
Yeah, exactly.
Yeah. But NHIF, as long as you're...
But exclusions to service are there, including, you know, if I'm talking about even the civil servant scheme, there are particular job groups that...
Of course.
And, but also, including all those hospitals, you are admitted, you can be given drugs, but then some particular tests can't be done. Including some tests that are done in the hospital, you have to pay for it yourself. Including a hospital as large as Kenyatta National Hospital. You you have to pay for CT scans, which are actually very routine tests required for diagnosis. So I think some of those exclusions actually also hinder, because there are patients who stay for quite a long time in a hospital because it's not covered.
Right. Somebody here says, kindly suggest to Mr. Kirgotty that the NHIF card should exclusively cover those patients with diabetes, hypertension, kidney disease and any other chronic diseases. Then for other diseases, Kenyans should have an option to have an NHIF card or not. NHIF card or not.
He says we
that you should exclusively cover these chronic diseases.
Yes.
That is what he's suggesting.
Yeah, and that
doesn't happen now.
Yeah, but that is what we are rolling out
in you're saying in February.
Yeah.
So it will exclusively cover.
Yes, we say is the diabetic this fund, we will have an NHIF within an NHIF. Those fellows who are sick with cancer and what have you, we have a pool that we will pay from there.
Seeking medical treatment abroad, what options exist under this scheme?
Doctors have been arms with me, saying that I've been sending people abroad because we don't have trust in our healthcare system. We're paying so much money to India or these other places. That is not the case. There is nobody that NHIF has sent out there without proper advice from their doctors and a clearance from the Director of Medical Services. So NHIF does not just wake up one day and say, the way I look at you, I think you should be treated out there. You see, we are an insurance, so we pay. Now, I don't know whether that is the civil servants asking for that question or whoever, because for now, it's only the civil servants that can access this.
There are more questions coming in.
But on that particular point, I think I have mentioned this before about the amount of money that we are spending abroad, and that is creating a lot of hype about medical care abroad. And what it does is that even care that we can get here sometimes ends up going abroad, because there's pressure actually sometimes from the public to go to India, including spending a lot of pocket money like Harambes, getting a lot of money just to go for treatment there for some things that sometimes we can't do here. And the bigger question, I know that they have to get clearance, and some cases are deserving. I know quite a number of civil servants who have gone. The bigger question is, are we worth spending 10 billion in India or other countries, or are we worth spending this 10 billion to improve these services? Because I believe even with 5 billion we can do tremendous changes in our healthcare system. And I think that's the bigger discussion that for me I would want to have. And especially I ask this question: how much is the significance of NHIF funds to improving public healthcare, to going into issues of compensation for doctors, for example, so that we can retain them? So those are the bigger questions that I think we may need to ask.
We take a look at what you've been saying again on Twitter. And we have why capitation is good for NHIF planning and eliminates corruption from service providers. We have Dr. Ahmed Kalebi. Universal health coverage is a numbers game and economies of scale. Let us all support NHIF to work for us. At Kipkorir Alf, the NHIF has a pool of resources. Invest this in improving hospitals, then people can be treated anywhere. At Fabricia Aura, despite paying 1,700 shillings monthly, I could not be admitted to a private hospital. Maybe you'll explain that. Cynthia_Oprah, people need to be educated about benefits of health insurance. Ignorance is a problem. And finally, Father or FR Kalinikos, the NHIF CEO, should acknowledge that hospital selection is a mess and limits success. And you are saying that that should not be the case. But we hope, like you say, they can go and report that, and that's something will be worked on. Somebody there you saw on the tweet saying they could not access private hospital services.
Well, yes, no, private hospitals.
Yeah.
You see, we have categories of hospitals in this country. We have the high-end hospitals, we have the mid-level hospitals, and as I said, we have government and faith-based hospitals. Certainly, we've signed contracts with all these hospitals. So maybe my member went to high-cost private hospitals, unfortunately, which NHIF had no contract with. So it's not that once you paid 1,700, you can just walk into any of these hospitals. You must find out whether it was accredited by NHIF
or not.
Yeah, or not, and under accreditation, what kind of agreements have we had with them?
Right. As you wind up, very briefly, clarify on maternity services. How does that work?
Yes, we have maternity packages. Yeah, this one is another walk-in, walk-out.
Okay.
Yes, so you.
From what period? Some people have been sending texts saying they are members of NHIF, or they just rolled into the scheme, NHIF insurance cover.
Yes.
And then after 8 months, they're told they cannot access services.
No. Well, unless of course you become a member of NHIF a month before you you go to deliver.
It's only a month before you go to deliver.
No, you must, as I explained earlier.
Yeah.
We are trying to avoid what we call advanced selection. That people must be members of NHIF at least 2 months if you are in the informal sector.
Okay.
If you are in an organized group, say a month.
Right.
Yeah, before you access those services.
Right.
Because we don't want this idea where you hear
so
NHIF
if it's 4 months.
It's okay.
That's fine.
That's okay. It's okay. You can keep on contributing. Yeah.
Right.
Yeah.
Let me get my winding comments, starting with you.
Okay. Thank you very much for bringing this discussion, because I think universal access to healthcare it's a big thing right now, and in our country we don't have even access to healthcare in the first place. If you're looking at issues of affordability, there's affordability to the cost of health, and then there's affordability of health insurance. I think we didn't discuss this also because the private insurers were not here. But some of the private schemes are too expensive just for even the working people. I think to conclude, I would want to say that it's a good thing that we have NHIF, but there's a lot that we can do to make it better. Bwana CEO, I'm sure, agrees. One of it is that I think we can have doctors really help in terms of trying to scale up some of these services. But more importantly is to have the funds that are collected to improve healthcare in this country, because the truth is that most of the money that NHIF collects goes to private providers, and private providers are not improving healthcare. So the people who can't afford healthcare, and majority of our citizens can't afford healthcare, they remain with no services, because if these county hospitals that are now going down due to mismanagement, and basically our public health facilities are not improving from a part of this fund, and I'm sure we can work out a way to do that, then even if we have all Kenyans register for NHIF, then we will still all be paying this money to India, because then we have no healthcare in this country. So for me, those are key things that we need to do. Number one, not just scaling up uptake, but also trying to make sure that there's quality services, and not just paying this money, because even this capitation, and I don't know whether those figures are true, but I think almost 50% of the costs of NHIF have gone to private providers and not public.
All right. Your winding comments.
Thank you very much, Hussein, and thank you very much for Kenyans for the support they have given the fund. I know we had a lot of controversies when we were enhancing these rates, but the fruits have come out to bear, that people now are accessing outpatient. We are increasing the rebates also, and very soon we will make major announcements on the benefits that we are going to give to Kenyans. We have an exercise going on of people choosing facilities. We had a lot of rush last Friday, and because Kenyans requested, we gave an extension of another 1 more week. up to the 15th, next Friday. And I hope everybody would have chosen a facility of their choice
by then,
so that we can be able to cavitate these facilities. And then they can be able to utilize these funds to get medication and build facilities for the betterment of our members.
Nicholas Nandasaba in Kitale, what is the maximum age to join NHIF? Can I take my mom who is 70 years? You said there's no maximum age.
No maximum age, 100, wherever, whatever. Bring anybody. Any social to NHIF.
Yes, and I think lastly, but just a very important point also on the private. There are a number of employed people who have private insurance and they're also paying to NHIF. I think we also must work out a way in which all this money can actually go to the less fortunate, the people who can't afford healthcare completely. And I think private insurers may need to give up, because one of the things that they do is to make sure that NHIF has paid for you the bed first. And you know that is also
can be taken care of by other private insurance providers.
Exactly. That can be taken care of the private insurers, because if you are paying 20,000 just on bed and someone else can't pay a bill at Kenyatta National Hospital or at MTRH, then I think we are actually denying access to larger pool of people. And I think the private insurers should be able to discuss this as well.
Well said, Dr. Ouma. I support you in that. You know, normally, well, it's a misnomer. Whenever you go get admitted, the first thing they ask you is, where's the NHIF card? Even if you have other
cards.
In a
private,
And now it is more complex when I have increased, you know, the benefits and the payment this hospital. So most of the times we pay for everything. But bring up that idea, let Kenyans debate, and we will see. This is a social cover. NHIF is where the healthy support the sick, and the rich support the poor. So this is a very social insurance.
CEO Simeon Kirgotty, NHIF, thank you so much for making time. For Monday Special tonight, and Dr. Ouma, Olunga, Secretary General, KMPDU. A final comment here on 22422. Rotich in Kisii says, NHIF capitation system is ideal than fee for service. It is really working well in Kisii County, with the exception of Government of Kenya facilities which have their unique challenges like lack of drugs. I urge the NHIF CEO to carry out evaluation for possible improvement. Thank you so much for your comments on 22422 and on Twitter. Thank you, gentlemen, for making time. For Monday Special tonight, there's somebody here who want to wish happy birthday tonight. That is none other than my colleague, Janet Bogwa. It's her birthday. And guess what? She'll be back here next week, Monday 18th. She'll be back on Monday Special with me. So thank you so much for making time for us. I'm Hussein Mohammed. Have a good night.